Nursing and midwifery disorders of menstruation gynecology. Disorders of menstruation. Amenorrhea is the absence of menstruation. It is a symptom, not a disease in itself, and is often physiological as in pregnancy. Classification. True. False. 1. True amenorrhea. Physiological. Before puberty. During pregnancy. During lactation. After menopause. Pathological. Primary amenorrhea refers to a patient of any age who has never menstruated and has passed the usual stage of puberty. Causes. 1. Severe chronic systemic diseases e.g. TB, nephritis, heart disease, HIV. 2. Endocrine disorder. The pituitary gonadotrophic hormones may not have developed e.g. pituitary dwarf. 3. Thyroid and adrenal amenorrhea, which can be due to hypo or hyposecretion of the glands. Hypothyroidism or Cushing's syndrome. 4. Local causes i.e. absence of or underdevelopment of the uterus or ovary. Secondary amenorrhea refers to cessation of the period after menstruation has been established. Causes. 1. Ovarian lesions. Polycystic ovary. Stein-Leventhal syndrome is the one most commonly recognized. It is associated with bilateral enlargement of the ovaries, which contain multiple follicular cysts and a dense stroma. Many of these patients are obese and have an excessive growth of facial and body hair. FSH is produced but not enough to cause uterine bleeding. 2. General systemic disease e.g. AIDS. 3. Oral contraceptive pills. 4. The irradiation or removal of both ovaries. 5. Hysterectomy. 6. Psychological causes e.g. shock, grief and change of environment. Nursing and midwifery disorders of menstruation gynecology. 9. Ischemic necrosis of the pituitary gland. Sheehan-S disease as a result of thrombosis of the pituitary blood vessels after profound hypotension and hypovolemia, most commonly caused by severe postpartum hemorrhage. 10. Starvation, though this may be associated with stress. 2. False amenorrhea. Cryptomenorrhea. This is a term used in a state where menstruation is occurring but is concealed because the vagina is occluded by a congenital septum or atresia. The blood collects in the vagina, forming a hematocolpos, and in neglected cases, the blood fills the uterus, called hematompium, and if it collects up to the tubes, it's called hematosopinges. Signs and symptoms. Lower abdominal pain and possibly acute retention of urine. Investigation and treatment of amenorrhea. Primary. 1. Observation of stature and body form. 2. Examination of the breasts and pelvic examination. 3. Hormone assays. 4. Chromosomal studies. 5. Radiological examinations and CT scan. 6. Ultrasound. 7. Laparoscopy. Secondary. I. Previous menstrual history. Roman 2. Change in patient S environment. Roman 3. General medical examination. Roman 4. Hormone assays. The ultrasound scan. Roman 6. Radiographic tomography or CT scan. Abnormal uterine bleeding. Menorrhagia. This is excessive or prolonged menstrual bleeding. Causes. I. Abnormal activities of the ovaries, thyroid and parathyroid, particularly at puberty and menopause. Roman 2. Upset of estrogen-progesterone balance. Nursing and midwifery disorders of menstruation gynecology. The uterine growth e.g. fibroid and polyps. Roman 6. Life in hot climate. Roman 7. Chronic subinvolution of the uterus. Roman 8. Salpingo-nephritis. Roman 9. Intrauterine contraceptive device. Exit may occur in acute leukemia, thrombocytopenic purpura, and hereditary capillary fragility von Willebrand-S disease. Epimenorrhea. The period occurs at frequent intervals and is excessively heavy or prolonged. Hypermenorrhea is when the bleeding is unduly prolonged. Polymenorrhea. The bleeding occurs at frequent shorter intervals but the loss is normal. Metorrhagia. This is heavy bleeding as well as being irregular, and this includes bleeding between periods. Causes. Urethrocaruncle. Polyp cervical, endometrial, and fibroid. Carcinoma of the cervix. Carcinoma of the uterine body. Estrogen-secreting ovarian tumors, granulosa and theca cell tumors. Postmenopausal bleeding. This is the bleeding from the genital tract which occurs after menopause. Metropathia hemorrhagica. These are irregular episodes of anovulatory uterine bleeding due to excessive and unopposed estrogens in the bloodstream, usually associated with a follicular cyst in the ovary. Clinical features. Age. The patient is usually 35-45 years, but in some cases it may occur earlier. Characteristic symptom. This is prolonged bleeding occurring after a short period, 6-8 weeks of amenorrhea. may get severe and prolonged bleeding which may lead to anemia. There will be no pain, but the patient complains of backache and lower abdominal discomfort. Treatment. Dilatation of the cervix and curettage of the uterus is done for diagnostic purpose. In a few cases, no further abnormal bleeding occurs, but in the majority, there is recurrence. Factors that influence further treatment. The importance or unimportance of preserving the uterus. Hysterectomy. Nursing and midwifery disorders of menstruation gynecology. When menstruation is sufficiently painful enough and incapacitates the normal routine activities. It has been customary to classify dysmenorrhea into two groups. Primary or spasmodic dysmenorrhea. 2. Secondary or congestive dysmenorrhea. However, it may be more useful to classify these cases into those due to evident pelvic disease, B. those without evident pelvic disease. Dysmenorrhea caused by pelvic disease. C. the type of pain experienced is very variable. D. it may precede the onset of period for about a week. Such premenstrual pain is common with pelvic inflammatory disease and endometriosis. E. the pain is always a dull ache felt equally on both sides of the lower abdomen and back, sometimes extending down the thighs. F. an acute colicky pain may occur if a fibromymatous polyp is being extruded through the cervix, and in some women, an intrauterine contraceptive device will cause colicky. Dysmenorrhea. G. the symptom may appear after years of painless menstruation. H. there may be complaint of other symptoms like menorrhagia, dyspareunia, or infertility. Treatment. Find the cause and treat it. Dysmenorrhea without evident pelvic disease. This type of menstruation occurs in young girls or young women. There is always a degree of pain during menstruation, however, severe pain only occurs in a minority, but there is no doubt it can be incapacitating and often leads to absence of work. Most women present at the age of 16-25 and may say they have had pain ever since the period started and the pain progressive. Presentation. The pain is colicky in nature, usually starting on the first day of the period. B. the pain may last for hours or continue for 2-3 days. C. the menstrual flow is scanty at first and the pain reduces if the flow is properly established. D. the acute colicky pain may be followed by dull ache. E. nausea and vomiting and occasionally diarrhea may occur. F. sometimes there is headache and fainting. Causes. The pain is usually due to spasm of the uterine muscle, which is sufficiently intense to cause ischemia. The cause of muscle spasm is not certain, but some theories exist, e.g. obstruction theory. The OS is the size of a pinhole and is associated with a narrow canal. Dilatation of the cervix is sometimes practiced but seldom affects a permanent cure. Hormonal imbalance. T. It has been suggested that excessive action of corpus luteum will cause the formation of thick menstrual decidua, which separates in large flakes or is a complete cast of the uterus, described as membranous dysmenorrhea, and that the expulsion of these large endometrial fragments causes excessive colicky contractions of the uterus. However, there is no evidence. Prostaglandin. Nursing and midwifery disorders of menstruation gynecology. Dysmenorrhea occurs only when ovulation has occurred. Anovulal cycles are painless. It is probable that necrosis of the endometrium is caused by prostaglandin, and this also causes spasms of the myometrium. Psychological factor. Although spasmodic dysmenorrhea is often described as psychosomatic because of the lack of any recognizable pelvic pathology, it is wrong to state that all patients are neurotic. Upbringing may have some effect. A girl may have come to expect that menstruation must be as painful. Nerve pathways neurogenic theory. Muscle spasms might be produced by imbalance of the autonomic supply of the uterus, though there is no evidence that there is any motor imbalance. Treatment. Prophylactic. Pay attention to the woman's general health, and it is advisable to inquire about her family and social life so as to discover and, if possible, correct any emotional stress. B. Reassure her after examination by telling her that she is normal and menstruation is a normal physiological occurrence. C. Encourage outdoor exercises to avoid congestion. D. Avoid constipation to avoid congestion. E. During an attack of severe pain, a hot bath should be taken and the patient goes in bed with a hot water bottle. Curative. Analgesics such as aspirin, codeine should be prescribed, but the use of habit-forming drugs like morphine, pethidine, or alcohol is unwise. Antispasmodic drugs such as atropine is ineffective. 2. Drugs which inhibit the production of prostaglandin in the endometrium may diminish myometrial contractions and therefore relieve dysmenorrhea. These drugs are prescribed TDSI, indumthacin 50 mefenamic acid ponsin 500 and flufenamic acid 200. 3. The most effective medical treatment is to suppress ovulation with the combined oral contraceptive pills containing 20 to 30 micrograms of estrogen, but progesterone such as dihydroestrone Gfestin is often used in a dose of 10 daily orally for 525 days of each cycle. However, if a patient wishes to get pregnant, hormone should not be used. Woman 4. D and C used to be done, but patients do not benefit from it, so it is condemned as it may cause abortion or premature labor due to cervical incompetence. Premenstrual tension. Nursing and midwifery disorders of menstruation gynecology. The underlying causes are obscure, but a transitory increase in water content of different body tissue seems to be the best explanation for symptoms such as weight gain, edema, bloating, and breast tenderness. This being due to minus estrogen progesterone imbalance, minus excess aldosterone or ADH, minus allergy to progesterone, minus hypoglycemia, minus hyperprolactinemia, minus psychogenic factors. Sodium and water retention is secondary to the hypovolemia produced by loss of vascular disease to the tissues. Clinical findings. These symptoms differ from woman to woman, but the pattern is consistent in the individual. Woman from cycle to cycle. Eye behavioral symptoms. Personality alteration taking the form of minus nervousness, minus irritability, minus agitation, minus unreasonable temper and sleep disturbances or fatigue, minus lethargy and depression. Violent crimes committed by women and suicide among women in the reproductive age group occur with greater frequency in the week before onset of the menses. Roman 2 neurologic symptoms. They include headaches, the most common, vertigo, syncope, paresthesia of the hands or feet, and aggravation of epilepsy. Day. Respiratory symptoms. Colds, hoarseness, allergic rhinitis, and asthma are usually worse in the weeks preceding onset of menses. D. Gastrointestinal symptoms. Abdominal bloating is almost typical of the syndrome. Less frequent symptoms are nausea and vomiting, constipation, colicky pain, and increase or decrease of appetite. E. Miscellaneous symptoms and signs. These include edema, temporary weight gain, palpitations, a sense of pelvic weight, backache, oliguria, enuresis, capillary fragility, easy bruising, skin problems, acne, neurodermatitis, and exacerbation of existing dermatologic diseases, breast changes, enlargement, heaviness, pain or tenderness, and eye complaints, conjunctivitis, visual changes. Treatment. Treatment is symptomatic and nonspecific. In severe cases, elimination of cyclic ovulatory. Nursing and midwifery disorders of menstruation gynecology.